Hello everyone and welcome to our module on the adrenal glands. The adrenal glands are endocrine organs located above the kidneys. If you look at this drawing on the screen here, you can see the two adrenal glands, one on top of each kidney. The arterial blood supply to the adrenal glands is via the suprarenal arteries. There are three suprarenal arteries on each side of the body, three on the left and three on the right. They are called the superior, inferior, and middle suprarenal arteries. The venous drainage is a little bit different on the left compared to the right. On the left side, the left adrenal vein drains into the renal vein, which then crosses the midline and goes to the IVC. In general, venous structures on the left side of the body have a longer course because they have to cross over to the IVC on the right side of the body. And this is true of the adrenal gland as well. It drains on the left side of the body into the renal vein, which then crosses the midline to connect to the IVC. On the right adrenal gland, because the gland is located very close to the IVC, it usually drains directly into the IVC and therefore has a much shorter course. If you were to cut the adrenal gland in half, you would see something like what is shown on the screen. You would see an outer capsule, and within that there would be two clearly distinct layers. The outer layer is called the cortex, and the inner layer is called the medulla. And as you will see, they serve very different purposes. The purpose of the cortex is to synthesize three groups of hormones. One group are called the mineralocorticoids, and the most important of these is aldosterone. The other group of hormones is called the glucocorticoids, and the most important of these is cortisol. And then finally, the cortex also synthesizes androgens like testosterone. The medulla, on the other hand, synthesizes epinephrine and norepinephrine, and it is under the control of the sympathetic nervous system. You can basically think of the medulla as a massive nerve that secretes epinephrine and norepinephrine into the systemic circulation. And just like many cells of the nervous system, it is derived from the neural crest in terms of embryology. The cortex, on the other hand, is derived from the mesoderm, like lots of different types of connective tissue. We're not going to talk about the adrenal medulla very much in this module. We're going to focus on the cortex, but I just want to remind you of the very important role the adrenal medulla plays in the sympathetic nervous system. This is a slide from our neurology module showing you the synapses of the parasympathetic and sympathetic nervous systems. And on this slide, you can see the adrenal medulla. It releases epinephrine and norepinephrine into the systemic circulation, and it's a very important component of the fight or flight response as mediated by the sympathetic nervous system. It is activated by the neurotransmitter acetylcholine via nicotinic receptors. Now what I'm going to do is go through the different groups of hormones released by the adrenal cortex, and I'll start by talking about the mineralocorticoids. So when hormones that came from the adrenal cortex were first discovered, they were named corticoids because they came from the cortex. And one group was called the mineralocorticoids because they had effects on minerals like potassium and sodium. So the most important mineralocorticoid is aldosterone, which I talk about in detail in the renal modules, and that's because it has very important effects on kidney functions. Its release is controlled by the renin-angiotensin-aldosterone system, or the RAA system, and when aldosterone is released by the adrenal cortex, it will promote the resorption of sodium and water, and it will also promote potassium and hydrogen excretion into the urine. And as I said, the most important mineralocorticoid is aldosterone, but there are also two other weak mineralocorticoids synthesized by the adrenal cortex. The first one is called corticosterone, and the other one is called 11-deoxycorticosterone. Here's a slide from our renal module showing some of the effects of aldosterone. So aldosterone can promote the insertion of sodium channels into the luminal side of the principal cells in the collecting duct of the nephron. It can also promote the insertion of sodium-potassium ATPase pumps in the interstitial side of the principal cells. The net effect of this is that more sodium will be pulled back into the interstitium or blood, and more potassium will go out in the urine. Aldosterone can also promote the insertion of pumps in the intercalated cells that secrete hydrogen ions, and this will promote the excretion of H+ in the urine. The second group of hormones synthesized by the adrenal cortex are the adrenal androgens. You're probably familiar with the androgen testosterone, but two other androgens are also synthesized by the adrenal cortex. These include DHEA, which is dehydroepiandrosterone, and also androstenedione. Now in males, this is a small contribution to the total androgen pool because they have the testes. However, in women, the adrenal cortex is responsible for about 50% of the androgens that are produced. And the place where these androgens are most clinically relevant is in the disorders called congenital adrenal hyperplasias, which we'll talk about later in this module. In these disorders, patients either over or underproduce these androgens, and this leads to abnormal sexual development. And these androgens are under the control of ACTH, just like cortisol, which we'll talk about next. Now we're going to talk about the third and final group of adrenal cortex hormones, and those are the glucocorticoids. And the most important member of the glucocorticoid family is the hormone cortisol. This is synthesized by the adrenal cortex. It is a steroid hormone which has a structure as shown at the top right of the screen here. The way it works is that because it is largely made up of carbons and hydrogens, it can easily pass the lipid bilayer and enter into cells. Once it gets inside, it binds to an intracellular receptor in the cytosol called the glucocorticoid receptor. Once it's bound to this receptor, it will translocate to the nucleus, and then it will activate or suppress gene transcription, and that's how it exerts its effect, by modifying the transcription of genes. And as I told you before, hormones that were discovered coming from the adrenal cortex were named corticoids, and this one is called a glucocorticoid because one of its many effects is that it will raise the level of glucose in the plasma. The release of cortisol by the adrenal cortex is controlled by the pituitary adrenal axis. This begins in the hypothalamus, where a hormone is released called CRH, which stands for corticotropin releasing hormone. This is released by the paraventricular nucleus of the hypothalamus. It exerts its effects on the anterior pituitary gland, and in the anterior pituitary gland, it triggers the release of a hormone called ACTH. ACTH stands for adrenocorticotropic hormone, and this hormone will then go and act on the adrenal gland and work via a cyclic AMP protein kinase A second messenger system to trigger the release of cortisol. That's a lot to remember, so I've shown it schematically in this picture on the right side of the screen. The hypothalamus releases CRH, which triggers the pituitary gland to release ACTH, and then the ACTH triggers the adrenal gland to release glucocorticoids like cortisol. Cortisol exerts negative feedback on both the pituitary gland and the hypothalamus, so that when the level of cortisol gets high, these glands shut down their release of CRH and ACTH. The release of cortisol from the adrenal gland is not constant throughout the day. It goes up and down in what's known as a circadian rhythm. So your serum cortisol level is highest in the early morning at about 6 a.m. It's about 10 to 20 micrograms per deciliter. It's lowest at night right after you go to sleep. It's less than 5 micrograms per deciliter. The reason for this is because cortisol is a stress hormone. It prepares us in a number of ways to encounter stresses in the environment, as we'll see in the next few slides. So evolutionarily, we have evolved to the point where we have our highest levels in the morning when we wake up and are likely to encounter stress, and our levels are lowest at night when we are least likely to encounter stress. And this has clinical relevance because clinically you rarely measure cortisol secretion with a single blood test. A single blood test is often not that helpful because the level is going up and down throughout the day. Cortisol is made up mostly of carbons and hydrogens, as you can see from its structure shown on the screen here. This means it is poorly soluble in plasma, therefore it needs a carrier protein in order to help it move through the bloodstream. That carrier protein is called cortisol binding globulin, and most of your serum cortisol, more than 90%, is bound to CBG. And just like thyroid binding globulin, cortisol binding globulin increases when the levels of estrogen go up, such as in women who are pregnant or women who are taking contraceptive pills. Now I'm going to talk about the effects of cortisol on the different tissues and processes in the body, and there are a number of different effects, but a way to remember them all is to appreciate that cortisol levels go up in times of stress. So for example, when the body is losing blood, the body is obviously under great stress and cortisol levels will rise, and its job is to make sure the body survives through that short-term stress. So it's going to maintain the most important processes. For example, it's going to keep your blood pressure up, it's going to make sure you have fatty acids and blood sugar available as fuel, but it's going to shut down everything else you don't need in order to survive through that short-term stress. So along those lines, one of cortisol's most important effects is to maintain your blood pressure. It has a number of effects on vascular smooth muscle. It increases the vascular sensitivity to norepinephrine and epinephrine, largely through alpha-1 receptors. It also blunts the vasodilatory effects of nitric oxide. And this has clinical relevance in patients who have high cortisol or low cortisol states. So for example, patients with Cushing's disease, which we'll talk about in another module, have high cortisol levels, and they often have hypertension because of the mechanisms I've described on this slide. Patients with adrenal insufficiency, on the other hand, have low cortisol levels, and they often have hypotension. Cortisol also suppresses the immune system. Remember, it is designed to keep the body alive through times of a life-threatening stress. So it doesn't want to divert energy towards replication of white blood cells. It wants to focus all the body's energy on maintenance of blood pressure and fuel. It's going to shut everything else down, and that includes the immune system. So cortisol has been shown to sequester lymphocytes in the spleen and the lymph nodes. If you measure the plasma levels of T and B cells, you will find that they are reduced in patients exposed to high levels of cortisol. Cortisol can also block neutrophil migration out of the vasculature and into tissues. This means that in patients exposed to high levels of cortisol, you will see a rise in the peripheral neutrophil count. This is not because more neutrophils are being synthesized, it's because the neutrophils are trapped in the vasculature and they cannot migrate out into the vasculature. Cortisol has also been shown to block histamine release in mast cells. It will lower the eosinophil count. And all of these effects I've described on this slide are the basis for using cortisol or cortisol-like drugs as immunosuppressive drug therapy, and we'll talk more about that in a minute. One particular immunosuppressive effect of cortisol is that it inactivates NF-κB. This is an effect that has been well studied in the basic science laboratory and that they like to ask you about on step 1. NF-κB is a very important inflammatory transcription factor. It mediates the response of the immune system to TNF-alpha. It also controls the synthesis of a number of inflammatory mediators, including COX-2 and PLA2 and lipoxygenase. So by inactivating NF-κB, this is one of the major mechanisms by which cortisol exerts its immunosuppressive effects. Because cortisol is such a potent immunosuppressive, drugs that have a similar structure to cortisol are often used to suppress the immune system or suppress inflammation. These are called corticosteroid drugs, or many people just call them steroids. One of the ones you will most commonly see used is prednisone. You can see that its chemical structure is almost identical to cortisol. It's given orally to patients with asthma exacerbations and lupus and many other inflammatory conditions. Methylprednisolone is an IV version of prednisone, often given in the hospital to patients with severe exacerbations of inflammatory disorders. I've shown some other molecules on the screen that are often prescribed as corticosteroid drugs. These include dexamethasone, cortisone, hydrocortisone, betamethasone, and triamcinolone. Some of them are more effective as creams, so they're used on the skin, but all of them have the same job, which is to mimic the structure of cortisol and therefore suppress the body's immune reaction. Cortisol has a number of effects on glucose. First of all, it leads to more glucose production in the liver. It increases the synthesis of enzymes like glucose 6-phosphatase and pepCK, and this increases the rate of gluconeogenesis. In addition, cortisol leads to less glucose uptake peripherally by muscle and fat. The net effect of both of these things is to increase the serum glucose concentration, and this fits with cortisol's role as a stress hormone. You want more glucose in the plasma to be available as fuel in times of stress. This also has clinical implications for patients who are in a chronically high cortisol state. They often have hyperglycemia. Another effect of cortisol has to do with glycogen. It leads to more glycogen storage in the liver by increasing the synthesis of glycogen synthase. This effect is somewhat offset, however, by the fact that cortisol enhances the effectiveness of the hormone glucagon, which leads to glycogen breakdown. And we'll talk about cortisol's effect on glucagon in a minute. Cortisol leads to the activation of lipolysis in adipocytes. This increases the number of free fatty acids available as fuel, which is important in times of stress. In patients chronically exposed to high cortisol levels, however, this leads to hyperlipidemia. Hypercortisolism is a well-described cause of increased total cholesterol levels and high triglycerides. In addition, cortisol can stimulate adipocyte growth, and as we will see in the module on adrenal disorders, patients who are chronically exposed to high levels of cortisol develop characteristic fat deposition. Cortisol leads to enhanced effects of the hormones glucagon and epinephrine. This can be helpful during times of stress. Over the long term, however, patients who have chronically high cortisol levels can develop insulin resistance. This is a big problem in patients who take steroids for long periods of time. They often develop diabetes. Cortisol has negative effects on your muscles, skin, and bones. Remember that it's designed to help you survive through times of short-term stress. So it doesn't want to divert energy towards growth of your muscle or your skin or your bones. It will shut down growth in those tissues. So muscles can atrophy from chronic exposure to cortisol. In the skin, there is blunted epidermal cell division and there's decreased collagen as well as inhibition of fibroblasts. The net effect is that patients with chronically high cortisol levels classically develop very thin skin. They bruise easily, and they can develop these purple stretch marks on their abdomen called striae. The striae are blood vessels in the dermis layer that you can see because the skin has become so thin. And in the bones, cortisol inhibits osteoblasts, and this means that patients who take steroids for long periods of time are vulnerable for osteopenia and osteoporosis, and fractures among patients on long-term steroids are a major clinical problem. Now that we've talked about the different classes of hormones synthesized by the adrenal cortex, we're going to discuss the biochemistry of exactly how those hormones are synthesized. And in order to do this, we first need to define the zones of the adrenal glands. Shown on the screen is a cross-section through an adrenal gland. You can see that it has a fibrous capsule on the outside. You can also see that it has an inner layer called the medulla, like I told you before. This purple layer here is the cortex, and the cortex is divided into 3 zones, and each zone synthesizes a different class of hormones. The outermost zone is called the zona glomerulosa. It sits just below the fibrous capsule. The innermost zone is called the zona fasciculata, and then the zone right above the medulla is called the zona reticularis. And as we will see, each of these zones makes a different class of hormones. Many students like to remember their order by remembering the mnemonic GFR, with the G standing for glomerulosa, the F for fasciculata, and the R for reticularis. Now let's talk about which hormones are made by each layer. Here's a zoomed in picture of the adrenal gland. The outermost layer is the zona glomerulosa, as I said before, and that is the layer that synthesizes mineralocorticoids like aldosterone. The middle layer is the zona fasciculata, and that's the layer that makes glucocorticoids, the most important of which is cortisol. The innermost layer of the cortex is the zona reticularis. That's the layer that makes androgens like testosterone and DHEA. And then finally, you have the adrenal medulla down at the middle. And as I told you before, that layer makes epinephrine and norepinephrine. Now I'm going to go through each layer of the adrenal cortex and show you how the hormones are synthesized biochemically. And I'm going to begin with the zona glomerulosa. As I said before, this is the outermost layer of the cortex just below the fibrous capsule. This is the layer that synthesizes mineralocorticoids like aldosterone. And one of the first things you should know is that all of these adrenal cortical hormones begin with cholesterol. Cholesterol is the basis for their synthesis. Cholesterol is then modified through a series of steps into all the different adrenal hormones. And as I show you these steps, I'm only going to show you certain enzymes, and that's because these are the enzymes that will be involved later when we talk about congenital adrenal hyperplasia. The other enzymes are not important for you to know, especially for step 1. So we begin with cholesterol, and before I show you the steps, let me show you the nomenclature for naming cholesterol. This is the standard nomenclature for cholesterol, and you'll see that each of the carbons are numbered, and if you know that, it's easier to make sense of all the different enzymes. So for example, there's an enzyme called 21-hydroxylase, and that adds a hydroxyl group to the 21 carbon. There's another enzyme called 17-hydroxylase, and it adds a hydroxyl group to this carbon. So if you know this, it makes things more easy to understand as we talk about the biochemistry. So we start with cholesterol. As I said before, it is converted into pregnenolone, and from pregnenolone, it is converted by 3-beta-hydroxysteroid dehydrogenase into progesterone. Progesterone is then modified by 21-alpha-hydroxylase into 11-deoxycorticosterone, and you can see that a hydroxyl group has been added to the 21 carbon. That's why this enzyme is called 21-alpha-hydroxylase. There's then an enzyme called 11-beta-hydroxylase, which adds a hydroxyl group to the 11 carbon right here. That creates a structure called corticosterone, and then corticosterone finally is converted into aldosterone. If you've watched the renal modules, you are aware that angiotensin II can stimulate the production of aldosterone from the adrenal glands, and the way it does this is by activating the enzyme responsible for the conversion of corticosterone into aldosterone. That enzyme is called aldosterone synthase. It is activated by angiotensin II. The zone below the zona glomerulosa is called the zona fasciculata. That is the zone that synthesizes glucocorticoids. What it uses as a substrate for glucocorticoids are molecules that come from the zone above, the zona glomerulosa. So as we saw in the last slide, in the zona glomerulosa, pregnenolone and progesterone were synthesized in the process of making mineralocorticoids. Well, some of those pregnenolone and progesterone molecules will percolate down to the next deeper level, which is the zona fasciculata, and they will be used as a substrate for glucocorticoids. The first enzyme in this process is 17-alpha-hydroxylase. It adds a hydroxyl group to the 17 carbon as shown here and here. This creates two molecules. One is called 17-hydroxypregnenolone. The other is called 17-hydroxyprogesterone. And 17-hydroxypregnenolone can also be converted to 17-hydroxyprogesterone by an enzyme called 3-beta-hydroxysteroid dehydrogenase. Once you have 17-hydroxyprogesterone, 21-alpha-hydroxylase, the same enzyme that was used in the zona glomerulosa is used again. It adds a hydroxyl group to the 21 carbon to make 11-deoxycortisol, and then 11-beta-hydroxylase, the same enzyme that also worked in the zona glomerulosa, will make cortisol from 11-deoxycortisol. If we go back to this slide, we talked before about how ACTH from the pituitary gland stimulates the adrenal glands to produce more cortisol. The way ACTH does this is by activating the enzyme desmolase, which converts cholesterol into pregnenolone. Desmolase cleaves the side chain of cholesterol, leaving behind a molecule of pregnenolone. Pregnenolone can then go through the biochemical steps to become cortisol. The zone below the zona fasciculata is the zona reticularis. This is the zone that sits just above the adrenal medulla, and this is the zone of the adrenal cortex that makes androgens. It will take molecules from the zona fasciculata and use them as a basis to synthesize androgens. So molecules of 17-hydroxypregnenolone and 17-hydroxyprogesterone, which we saw on the last slide used in making cortisol, these molecules can percolate down into the zona reticularis and be used to make androgens. 17-hydroxypregnenolone can be converted into DHEA. 17-hydroxyprogesterone can be converted into androstenedione, and DHEA can also interconvert into androstenedione by the enzyme 3-beta-hydroxysteroid dehydrogenase. And then finally, androstenedione can be used to make testosterone. And here's a slide like you can find in your textbook showing all the steroid reactions that occur in the adrenal cortex. So the process begins with cholesterol, which can be used to synthesize aldosterone in the zona glomerulosa. Some intermediates can cross over into the zona fasciculata and become cortisol, and other intermediates cross over to the zona reticularis and can become androgens like testosterone. And in another video, I'll discuss congenital adrenal hyperplasias, and in those disorders, a baby is born deficient in one of the enzymes shown on this slide. That results in an inability to synthesize cortisol and also some of the other hormones in the adrenal cortex. I'll finish this module by talking about ketoconazole, which is an antifungal drug that can be used to treat fungal infections because it blocks ergosterol synthesis in fungi. And I talk about this in more detail in the infectious disease section in the video on antifungal drugs. But the reason I'm talking about ketoconazole in this video is because it has a number of inhibitory effects on enzymes in the adrenal cortex. In particular, it's a potent inhibitor of the enzyme 1720 lyase, which is found in the adrenal cortex. It's also found in the testes in males, and this enzyme is necessary for synthesizing androstenedione and testosterone, which are androgens. So when you inhibit this enzyme with ketoconazole, you get less production of these androgens, and in males this can lead to gynecomastia, because anytime in males you have less androgen effects, you will have relatively more estrogen effects because there's always some estrogen found in males, and this can lead to stimulation of breast tissue and gynecomastia. In addition, at higher dosages, ketoconazole inhibits a couple of enzymes that lead to cortisol synthesis. It can inhibit 17-alpha hydroxylase and desmolase, and by blocking these enzymes, there's less cortisol synthesis. And for that reason, you can use ketoconazole sometimes to treat Cushing's syndrome, which is a disorder I talk about in the video on adrenal disorders. But in Cushing's syndrome, the adrenal gland produces too much cortisol, and that's why ketoconazole can sometimes be used as therapy. If we go back to this slide, ketoconazole can inhibit the enzyme 1720 lyase. That will result in less production of testosterone, and that's why gynecomastia can be a side effect in men. In addition, at higher dosages, it can inhibit the enzyme 17-alpha hydroxylase and also the enzyme desmolase. This will result in less production of cortisol, and that's why ketoconazole can sometimes be used to treat Cushing's syndrome. And that concludes our video on the adrenal glands.